This video shows my technique for performing a remplissage as an augmented anterior stabilization procedure. In this cadaveric demonstration, we're operating on the left shoulder. I'm viewing from an anterolateral portal, which is placed just anterior to the supraspinatus over the biceps tendon. You can see the Hill-Sachs lesion here on the right of the screen. And we're preparing to place an anchor, placing the anchor through a standard posterior portal. It's going through the posterior rotator cuff. This is a relatively small Hill-Sachs lesion, so we're only using one anchor. But you could use two if in a larger patient or with a larger Hill-Sachs lesion. I think it's important not to place this anchor too medially. Even if it is a large Hill-Sachs lesion, I may not put it exactly at the articular surface. I try to keep it about 1 centimeter to 1.5 centimeters off of the insertion of the rotator cuff. Here I'm making a posterolateral portal, and I'm placing an 8.5 millimeter diameter cannula through the deltoid, but making sure that it's superficial to the rotator cuff. And you'll see I'll sweep a little to really make sure that that space is cleared out and that I have that cannula again deep to the deltoid fascia. And now through that cannula in the posterolateral aspect of the shoulder, I'm then going to place a bird's beak tissue penetrator, and I'm going to start to retrieve my sutures in a mattress configuration. Just like I think it's important not to place the anchor too medial, I also think it's important not to pass these sutures too medial either. You want these sutures to be going through the tendinous portion of the rotator cuff, and usually it's about 1 centimeter to 1.5 centimeters away from the insertion. It's helpful to start inferior and then just work superior. And it's also helpful to have your assistant help you with suture management here as well. We have one more suture. This is the most superior suture. Again, you can see it's somewhat difficult to get through the tissue, which indicates that I'm going through the tendinous portion of the rotator cuff and not just the muscular portion. So once the sutures are all passed, I then take the sutures and clamp them against the cannula. And then through that anterolateral portal, I place my trocar and I sweep and find the cannula. Since that cannula has been pressed down onto the bursal surface of the rotator cuff, theoretically that cannula is then protecting the sutures. So that when I come through the posterior portal with my shaver, I can be pretty aggressive with finding the cannula and have faith in knowing that the sutures are being protected by the cannula in the bursal or subacromial space. So here, again, looking from the anterolateral portal, and that cannula is through a posterolateral portal. I'm going to retrieve the sutures that I'm not tying through the posterior portal, and now just do a surgeon's knot and tie these down. Again, I think the real trick to this technique is using this cannula to protect the sutures. Again, the move would be to push the cannula so that it's abutting or right on the bursal side of the rotator cuff, and then snap the sutures so that it holds the cannula in that position. And then be aggressive with sweeping with the trocar for the scope to find the cannula, and then use your shaver having some confidence of knowing that the sutures are protected by the cannula. Once they are found, again, typical arthroscopic non-tying techniques, I do think it is important to find these sutures and actually tie these in the bursal surface. I think when these are performed blindly, more often than not, you can tether the deltoid fascia, and I think that can be a source of pain. Here you see the infraspinatus into the Hill-Sachs lesion. So thank you very much for your time.